This is the Functional Rehab Podcast with your host, Dr. Ashley Mack. So you wake up one day and realize that your foot has fallen asleep. And, maybe your foot has fallen asleep in the past when you've been sitting in a chair for too long, or you've been having a wallet in your back pocket. And so you think that this is just temporary. So you get up, you shake your legs out, and you're kind of walking around. You notice within the first 4 to 5 hours upon being awake, you're like, man, that numbness is still there. So then what do? You go to Dr. Google and you say foot numbness. And if you go through the traditional route and you go take a look at WebMD, they're like, holy crap, it's cancer, right? And it ends up being pretty scary when it comes to trying to figure it out and who you can see to actually manage your foot or leg numbness. And so today is a very special guest, physical therapist and a good friend of mine. And I had a chance to know him for a couple of years and interviewed him on a previous podcast. But here I have Dr. Dave Candy, physical therapist. And today we're going to be focusing on the differential diagnosis and understanding of foot and leg numbness. Dr. Dave, good to see you. Thank you so much.
Good talking to you again, Ashley.
I'm so excited because I think that oftentimes when people get presented with issues, just problems in general, what happens in our heads as clinicians is kind of a black box. And what ends up happening is that patients are kind of sitting there thinking, well, what are they thinking about? What do they think the diagnosis is? And I think it's extremely important for patients and people to understand a little bit into what goes on and to trying to figure out what the problem is, because once you can figure out what the problem or the source of the problem is, that's when you can start to really emphasize treatment. Unfortunately, there are some cases when patients come in to see us, say as a clinician, if you're seeing 3 to 4 patients an hour, you don't really have that opportunity to, share or even just figure out what the issue is. So I'm excited for us to take a deep dive into that. Now, being that this is a new, entirely different show, for the listeners out there who haven't quite met you yet, tell us a little bit more about yourself and what you do.
Sure. I'm a board certified orthopedic physical therapist in St. Louis, Missouri. I own a practice called More for Life. We also have a YouTube channel that shares a lot of similar tips to this. So I just like helping people, and I really enjoy the problem solving aspect of physical therapy and just healthcare in general. Putting together the pieces and solving the puzzle has always been something that I've really enjoyed. And there's a lot that goes on in here when you're talking to a clinician that you don't necessarily see as a patient. So I'm glad to have the opportunity to kind of share what goes on behind the scenes.
100%. One of the reasons as to why I got so interested in linking up with Dr. Candy here was that on LinkedIn, he was posting some really great information when it comes to understanding conditions, but also how to manage them as well. So I said, I got to talk to him and got to pick his brain and share the knowledge with the world. So let's talk about differential diagnosis. I think it's a lot of syllables, right? But it's a very important part of our treatment process as physical therapists, and actually for most part, a lot of practitioners in general, right? Like we have to figure out what the problem is. So for starters, let's talk about what is differential diagnosis, or what is a differential diagnosis?
Well, basically, it's just narrowing down between several different alternatives that could cause symptoms and finding the most likely one that's going to cause the symptoms. And really, from our perspective, or any professional's perspective, the first level of that is just, is this in my scope of practice? Is this something that should be in my office and should be treated in my office, or is this something that I need to refer out? And then after you've gone through that and decided, yes, this is something that I can manage, okay, what condition am I going to manage at that point?
Especially because the conditions will also dictate the treatment. And I think what ends up happening, and on my previous podcast, we talk about sciatica pain, but sciatica is really just an irritation of the sciatic nerve, which could be caused by multiple different things. And because of that, it's our jobs to understand, well, what is the cause of this sciatic nerve irritation? Is it going to be the spine? And if it is the spine, are we looking at a disc herniation, or are we looking at a stenosis? If it's looking at the hips, are we looking at more of a piriformis syndrome? But if it's a piriformis syndrome, well, why is that happening in the first place? And then we just continue to move further down the chain. And it is especially important, especially when you are dealing with something which isn't necessarily pain. It's more so the numbness aspect of it. And so for today's structure, I thought it would be a great way to really show the differential diagnosis, which then leads into our clinical decision making, as to kind of walking through like a miniature or maybe like an abbreviated evaluation of someone's actually coming in for foot and leg numbness, which is actually going to be the main focus of today. So say, for example, someone comes in, all right, I'm coming into your office and I'm complaining. I'm like, hey, Dr. Candy, my foot, my leg is a little numb. And it's been like that for a couple of days, maybe like a week or so. Like, what do we do there now? It's like, I'm in your office. I'm telling you that's the problem. What happens there after I present it to you?
Well, essentially, we want to find out more details about the problem, and your diagnosis can only be as good as the information you have coming in. So the first step is just gathering information. And actually, I had two similar cases like this today, back to back, where someone came in with foot numbness, and one person just assumed it was neuropathy. Her doctor said, well, it hurts at night, soak your feet in hot water and put socks on at bedtime, and that wasn't helping. But they really didn't delve into it or ask very many questions other than, your feet are hurting or your feet are numb at night, put socks on and use hot water. Diabetic neuropathy is probably the first thing that many people think of when they hear foot numbness. But you need to ask further questions to find out if it's that or something different. And in both of these cases, they were more mechanical things that you and I should be treating. So I guess the first step is just asking the right questions and getting the right information from patients. And as someone listening to this, probably knowing what information to give your provider will help them to make the proper diagnosis.
100%. And I think one of the challenges / also, I think it's like a really great way. It's a great demonstration of skill to be able to ask the right questions, which then brings up into what are some of the questions that you would ask your patients when they come in and complain of this. And I'm going to premise with the fact that there are some folks, some patients, and you probably identified this yourself, Dr. Candy, that there are some folks who are actually really good at telling the whole story. Like they probably played it in their head and they said, okay, this is the information that's the most important. But when it comes to the subjective, where we're asking questions and getting a little bit more of a history, what are some of the key questions that you ask that helps you get a better idea of what could be going on?
Well, the first thing I'd want to know is the location. Is it 1 foot or is it both feet? If it's 1 foot, you're probably thinking something more mechanical. If it's both feet, it's either something closer to the spine or maybe a systemic problem. What if it is 1 foot or both feet? Is it the whole foot? Is it just the outside part of the foot? Is it just the big toe? Is it just the bottom of the foot? Is it both feet kind of up to like where a stocking would be? And those all kind of describe different patterns of referral. And if you know your neuroanatomy pretty well, you can start to determine based on just location alone, these are the potential things that could cause symptoms in that area. You'd want to know other associated symptoms. So is there any pain associated or is it just the numbness? You'd want to know how long it's been going on, how intense it is. Those are some of the initial questions that I would ask.
100%. I appreciate you breaking that down specifically, because I think one of the challenges that patients face when they go into, go into a physician's office, one of the challenges is the fact that oftentimes a physician's visit is probably about 15 to 20 minutes. So the big issue is like, well, how do I fit all this stuff in during that time? And I think that's one of the benefits and advantages of working with someone like you or me, because we actually set aside, or the work that we do actually allows us to set aside, we'll say 30 minutes to an hour to actually be able to get the necessary information. And I think what a lot of people, what often gets misunderstood is the difference between, are we dealing with, say, a peripheral nerve irritation? Are we dealing with more of a central irritation or more of a systemic irritation? So when it comes to say like foot and leg numbness. Those are kind of like the three major categories of what we're looking for. So when it comes to say more of a peripheral nerve irritation, what are some of the signs or what are some of the questions or details that would show you or kind of highlight that it's more of a peripheral nerve issue? So like especially when it comes down to the foot and leg.
Well, again, if it's unilateral, one leg, I would almost immediately start thinking a peripheral nerve, which includes, a unilateral nerve root on one side of the spine, but basically everything outside of the spinal cord and the brain. So if it's one leg, that would lead you down that pathway, and then you'd want to find out, the exact location of it, when it happens. Is it all the time? Because usually a peripheral nerve problem is going to be more mechanical. There are things that make it better. There are things that make it worse. Even if it's constant, there are probably things that make it worse and things that make it not quite as bad, versus something that's more systemic. It might just be relatively constant all the time, and movements that you do or positions that you get in might not really affect it. Finding out times of day, is it just at nighttime? Positions that you're in, like driving in the car or sitting or standing or walking, those would all be factors that could affect a peripheral nerve problem.
And you bring up, which I'm going to go ahead and refine those categories a little bit more. You're separating one from like more a mechanical dysfunction or challenge or issue to more of a systemic issue as well. So from the mechanical standpoint, it's something that is going to be influenced in movement and also will change throughout the day based on movement and position. On the systemic side, well, I'm going to premise with like mechanical stuff. This is stuff that we can work on specifically. That's something that's in our wheelhouse. But from a systemic standpoint, what are a couple of those signs or details that you look for that helps you think, all right, this might be a little bit outside, this might be outside the scope of what I can provide?
Well, if there's like no mechanical premise based on, either history and or physical exam, like you can't provoke it with a physical examination, and the patient says, it's really no different whether I'm sitting, whether I'm standing, whether I'm walking, no movements that I do set it off. Doesn't matter whether I'm wearing tight shoes or tight socks. Those would be things that would start to make you think more systemic. If it is, in both legs, that wouldn't be something certainly in one leg. It could be a central spine problem, but it wouldn't be something, say, in the leg that's causing it if it's in both legs. History, like other medical conditions, for example, diabetes, I mentioned it earlier, is one really common thing. Thyroid issues, asking about diet, there are certain vitamin deficiencies that can cause more systemic problems, things that vary after meals. If they've had a recent illness and that set it off, those are all things that could indicate more of a systemic issue.
And during the question segment, the history taking and some clarifying questions that you ask, what are some of the questions that you ask that some of your patients might have observed that no one has ever asked them that question before? Because I get this a fair amount with some of the questions that I do follow up. I'm just intrigued with, with your background and your expertise. You ever ask a couple of patients that like a certain line of questioning and they're like, oh, like no one's ever asked me that. Have you ever encountered that?
Quite a bit. I mean, a lot of times, even just the location question, that if a physician has 5 minutes, you might say my foot's numb, and they kind of leave it at that. Versus, well, is it the big toe? Is it the small toes? Is it the whole foot? Is it the top of the foot? The bottom of the foot? Does it go up the calf? Does it go past the knee? Does your back hurt as well? Kind of those level of details, because and this might be a little beyond the scope of what you were asking. There are a couple different ways of reasoning. You can use deductive reasoning, which basically starts with everything in the world is a possibility, and we're going to narrow it down. And you can also start from inductive reasoning, which is, I've seen this in the past, and I'm assuming this is going to be that case. Expert clinicians tend to use more inductive reasoning. They draw from past history. I've seen this before, but that's prone to some flaws. There can be reasoning errors that happen when you do that. It's faster though. When you group things based on signs and symptoms, and I've seen that before, it kind of almost stereotyping conditions, it's much faster. And if you're in a doctor's office and they have 5 minutes to see you before they get on to the next patient, that, oh, this looks like that, try this and see me back in 2 weeks. Versus if you use that and say, yeah, I've seen something like this before, and then you go back and then start using deductive reasoning to say, well, what would make this not this? What would make this not that? What would make, what would happen if this was this condition? What would happen if it wasn't this condition? What other conditions could cause things that look similar to this? And what would be the difference between the two? Boy, I lost track of what you actually wanted from that question. But
yeah, you answered it perfectly. I think we start off, it's like, oh, well, what's some of the questions that you would ask that patients were like totally shocked that you asked? But your answer was way better than what, a couple examples of what that would be like, because what's important throughout problem solving, especially when it comes to, say, pain management or rehab, I think that for the most part, say, going through, say, post-surgical, like a hip replacement, knee replacement, there are some like rehab and surgical protocols that, you follow. It's a little bit more simple, a little bit more straightforward. But when it comes to trying to identify something or fix something that isn't necessarily related to, say, a trauma or a surgery, that's where we have to ask those deeper questions to be able to say, like, where is this located? How does this influence you? I think one of the really interesting questions that I've come across that not too many folks do bring up is that if someone they say, every time I run, my foot falls asleep, right? And so when that happens, one of the questions that I will actually ask is, well, how long can you run before that actually comes on? And a lot of people they'll be able to answer it exactly, but oftentimes people will say, I've never been asked that question. And so it actually helps me figure out a couple of different things in regards to the length of time, how are they running, strength, endurance, like all that other stuff. And it's a very crucial piece of information that actually allows me to go down the rabbit hole of like, okay, well, what are we going to be looking for? Which then actually brings me into the second part of the evaluation or even the interaction is like the actual like physical exam, right? So with physical exam, we're going to have these tests and measures to actually be looking at what's going on. And so based on the questioning that we get from our patients, we are going to focus on some specific tests that would actually allow us to get a better idea. But when it comes to, say, transitioning into the physical exam, a lot of people are like, all right, physical exam, I'm going to see some range of motion. What are some key things that you look for specifically when you're having someone move or you're feeling someone or feeling around their body to figure out what the issues are?
This kind of gets back to that combining deductive and inductive reasoning that from just history alone, you want to gather a list of, okay, these 5 different things based on all the different questions that I've asked could potentially cause these signs and symptoms. And then just rather than doing a laundry list of, well, I'm going to check range of motion, I'm going to check strength, I'm going to check special tests, knowing what do I want to gain from this piece of knowledge? Much like getting an MRI or an EMG or an X-ray, don't do the test if it's not going to change your clinical reasoning or not going to change the treatment. So say, I'm having numbness in the outside of my foot, and the possible things that could cause that are a peroneal nerve problem, a sciatic nerve problem at the buttock, or a pinched L5 nerve root in the lower back. Then I'd want to do tests that would differentiate between, okay, what would be positive for one thing and negative for another to tell the difference between, okay, is it A, B, or C?
Forgot to unmute myself right there, but 100%. It is important to be able to say like, what could be these issues? And I'll be honest. I remember early on in my career, we'll say the first 1, maybe 2 years, most likely the first year, whenever I was presented with a lower extremity dysfunction or even numbness like this, the first and only thing I would probably go to is actually just looking at the ankle and foot. And what ended up happening was the fact that these folks, without actually having to assess their knee, their hip, their spine, there was a whole bunch of other areas that could have been affecting this nerve irritation in the first place. But me focusing specifically on the foot, because I was like, oh, this is foot specifically, I wasted a lot of their time. I had to learn the hard way where my patients weren't getting any better and they left because they got tired of just doing the same thing over and over again. So now as a clinician, the clinician that I am now, I'd be able to look at, okay, well, here are these issues. It's very, very important because what's nice, what can be frustrating, but what's also extremely nice at the time is the fact that if you're dealing with foot numbness, you have the foot, you have the knee, you have the hip, you have the spine, but then you also have the muscles and structures that run between those joints as well, which means that not only there's an endless amount of interventions that can actually treat those specific joints, but then also there are specific just modalities and ways to actually apply them all. And so, which then brings me on to, okay, so we have the actual physical assessment, which is used to actually confirm what our suspicions are based off of the questioning that we're getting from these patients. So as we start developing a little bit of a better idea of what's going on, what we're suspecting, we then transition onto, okay, possibly the treatment point of it, right? We haven't gotten to the education because we're still trying to figure out, is what we're suspecting actually truly the issue, right? So we go into the treatment aspect of things. And so kind of run me through the thought process of selecting the treatment and how do you assess your effectiveness of that treatment to help you decide, what the next steps are?
Well, with relatively, let's say, fairly harmless treatments like physical therapy, the treatment can actually be used as an assessment. And, physicians do the same thing with things like cortisone injections, where I think it's coming from here. We're going to shoot it up. We're going to put some numbing agent in that area. And if it gets better, then that's probably where it's coming from. So those are sometimes used diagnostically. The same thing for us. If we expect that the problem is coming from the ankle, then we'll treat the ankle and see if the symptoms are any different. And the skilled clinician would say, okay, yes, this is getting better. We're probably on the right path. Or no, this isn't getting better. I need to go back and reassess. What you and I probably did when we were first starting out is that we assumed it was the ankle to start out with because that's where the symptoms were. And then we treated the foot and ankle. And then when it wasn't working, we got frustrated because it wasn't working, rather than saying, well, if my treatment isn't working, then maybe my diagnosis was wrong to begin with.
For sure. And I love the fact that you said that the treatment is also the assessment. I often talk about with the patients that I work with, I'll say, listen, I have a suspicion based on what you're telling me and based on what I'm seeing right now, it's going to be X, Y, and Z. We're going to go through a couple different movements, and based on how you actually react to those movements will actually either support my suspicions or help me change direction. And I think actually being able to set that specific expectation, being able to say, okay, now that we have some good information, we kind of have an idea, and here we are going to be really embarking on this journey to be able to say, this is how we can solve the problem. But everything that we actually do is going to be focusing specifically on treating the problem and addressing the problem. And I think it is important to be able to see, like, the category that I like to use with the classification I like to use is often, do you feel better, worse, or the same? I think it actually allows me to just structure things a little bit better. And not only would it be from like an actual physical change that, not only like a subjective change that the patient feels better, worse, or the same, but also if there is a restriction in range of motion, is that going to be affected by the intervention as well? So my question for you is, at what point, so I think that this is where clinicians and patients get hung up, is trying to figure out, well, how long should I be like pursuing this one, say, treatment modality. So like, say, for example, like the most common thing that people will often see is, let's just say for the ankle, like for the foot and the leg, they're like, okay, we're going to start at the leg. We're going to start at the ankle and foot. We're going to be doing, say, like these ankle alphabets. And then we're also going to do some resisted dorsiflexion or like one of these exercises. When you're dealing with, say, foot numbness, right? How long would you usually recommend, or would you usually follow through with one specific set of interventions before you start to say, all right, this isn't going to be as effective as I think, time to go ahead and reassess the board? Because I know it's going to be a consistent reassessment, but what's some of the time, like, do you give yourself a time domain in regards to, okay, let's run with this for X amount of days? Tell us a little bit more about that.
I wouldn't say it's a certain X amount of days, but typically, ideally, I like to see a change within one visit. After, it might not be better, and oftentimes it's not cured in one visit, but there should be some change, even if it's worse. Like even if you treated something and the problem gets temporarily worse, you kind of have an idea that maybe I did the wrong thing or did it too intense, but it was the right area. It supports the diagnosis. If there was no change, and there's really no change for 2, maybe 3 visits at most, I'm moving on to something else. So I think the days of where the typical physical therapy model is you do the evaluation, you set up the plan of care for 4 to 6 weeks, and then you reassess in 4 weeks and see if things are getting any better. And that's just way too long to wait. It just needs to be a continuous reassessment and modification throughout. And ideally, I'd like to see at least some change within 1 to 2 visits, even if it's just a little bit in the right direction.
I am right there with you. It is important to be able to get something, because for the most part, like if you go into your clinic and you're like, oh, I don't feel anything at all, I don't feel any better, I don't feel anything, then in a way it's hard to figure out if you're actually even getting any better. And I think that's one of the things that I highly respect about, say, clinicians like yourself, like and the teachings and the training that you've gotten, is to be able to take all this information, put it together, and be able to say, okay, well, we should be able to influence something. I think that's the big thing, is like influencing something, whether making it better or worse. I think also what's interesting throughout all this is that, I've encountered patients who are like, I've worked with this PT for 6 weeks. They've given me the same 10 exercises, and the PT just told me that it's just going to take a little bit of time. So let's talk about, say, just from the time perspective, because I know that if we also have to take into account, say, if it is a true mechanical issue and not a systemic issue, that we have the acute stage, the subacute, and the chronic stage. Right now, in the acute nerve irritation, there's going to be some inflammation, there's going to be some swelling, right? But that usually happens within just like the first 48 hours to like 2 to 3 weeks. But then once we transition into that, what's interesting is, I know that in some cases, the recovery time and the degree of change is a little bit longer, right? In some cases, we would call them slow responders. So I guess my question throughout this is, how can we manage expectations when it comes to the degree of change based on how long we've been dealing with an issue like foot numbness?
Well, I would say that the chronicity level does have quite a bit to do with it. Something that's been going on for a really, really long time. I actually got an email from someone who had been having numbness for 6 to 7 years. And at that point, like, you start to question, is it repairable? Because nerve issue, you can get permanent nerve damage. And after a number of years, the prognosis of it getting fully better are not great. With something that's really, really acute, a lot of times you are managing chemical inflammation in the first couple of days to a week. And so mechanical treatments, like things that you and I do, may not be well tolerated within the first week while the nerve's just still really hot and irritable. And so it is maybe more of a case of rest or even medication management in the first initial stage just to calm down the irritability level. And then once it's become more subacute or chronic, like 3 to 6 month range, then usually mechanical treatments are a little bit more tolerated. I think it also depends on the patient's medical history because we've been kind of categorizing things as mechanical or systemic, but they're not mutually exclusive. So you could have a patient who has diabetes and also happens to have a peripheral nerve problem, and they're probably going to recover from that peripheral nerve problem slower than someone who, say, didn't have diabetes. So those things can be additive. So education is important, helping to set up the proper healing environment, whether that be diet or exercise or nutrition. Well, I said, but you get the point. Like there are lifestyle things that go hand in hand with proper nerve healing. Sleep is another one. If you are not sleeping, your nervous system is kind of like on fight or flight mode, and that doesn't promote proper healing. Psychological issues can play into it too, because anxiety and depression, things like that, those all affect your nerves. What goes on in your brain, it just as much affects your nervous system as what's going on in your body. And I mean, we could delve into the biopsychosocial aspect of pain, but when you're dealing with nerves, the biggest bundle of nerves in your body is right in between your ears. So you have to take that into account as well.
For sure. When I was in school, our capstone project, as one of the things that really categorized our transition into a doctorate program, was we did a review of the literature. And what we're discussing today actually ended up being like a very interesting subject that I was pursuing when I was in school. And it was this aspect of what happens what's happening in the area that's sitting between your ears. And for that, we were talking about specifically peripheral nerve injuries. And there definitely is research showing, and a lot of research showing that parts of our brain will have a specific area dedicated to a specific part of our body. And so what ends up happening, they call it the somatosensory cortex, right? And so what ends up happening is, like, whether you're having pain that's caused by more like a spinal issue or a peripheral nerve issue, the sensations all go to the same part of the brain. And so what ends up happening is that the brain will receive these signals and interpret it based on whatever it sees fit, whether it be sensation, pain, danger, or whatever's needed. And I'm glad that you brought that up, just being able to say, like, not only are we dealing with something that happens with the nerves or like actual specific tissues, but also what's happening within our brain as well. And I really appreciate you bringing that up, because oftentimes, we don't necessarily get a chance to get there. In some cases, it takes a while for us to actually say, okay, could it be more of a centralized issue? And by the time we come up with that, people are already pretty frustrated, and they might maybe move on to a different clinician because they're not getting the results that they need. But it really is ultimately based on the questions that we asked and the information that we need to specifically gather from the people, which is why it's so important to have the differential diagnosis, the clinical decision making. And I mean, I think one of the most important parts that you said, Dr. Candy, was the fact that our treatments are also assessments as well, which is often very important. And listeners, my challenge for you is, if you're going through active physical therapy, think about how often your provider is asking you, like, how are you doing? And it's beyond like, hey, how are you? It's really more so like, hey, tell me a little bit more about your symptom behavior. And then that way we can start to get a little bit more of an understanding of what's the type of process that you're going through when it comes to your management of this as well. So, Dr. Candy, anything to add there?
Actually, be honest with your clinicians. The physical therapists are in general very, friendly people that want to help. And as a result, a lot of times patients will kind of say what they think they want to hear because they're nice people. but that's not helping them to help you to get better. So be very honest. Like if something's making you better, making them worse, tell them flat out, even if it's like not what they want to hear or not what you think they want to hear. It's going to be better for you if you give good information as to how you're responding, whether that be positive or negative.
I appreciate that. It's extremely important. And I don't know, you may have encountered this, but I'll ask a patient being like, hey, how are things? Like, how is how is your symptom progression? And they'll say, Ashley, I'm so sorry, but X, Y, and Z isn't working. And I often have to say, you don't have to apologize at all. Thank you for telling me this, and it helps me do my job a little bit better. So I think it's very important. I'm so glad that you brought that up. Dr. Candy, I mean, you're brilliant, and it's one of the reasons why we get connected. And I'm so glad that you were able to, take the time out of your day to share a little bit into the differential diagnosis process and just understanding, how can we navigate just the overall session or interactions with our providers. For the listeners who need a little bit more help or want a little bit more clarification, what's the best way to get in touch with you?
Probably the best ways are either through our website, which is m4lpt.com, as in more, 4 life physical therapy. Or we do have a YouTube channel, which is youtube.com/more, 4 life.
Awesome. Dr. Candy, thank you again.
You're welcome. Thanks for having me.
No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.